people with disabilities are dying 20 to 25 years earlier than the general population. Why is that? Eventually, after years and years and years of sleep apnea, eventually after years and years and years of poor health practices, poor diet, if they're sitting on the couch watching TV, but they're behaving themselves and I don't have to work any harder, I'm cool with that. That's why people are dying at the age of 50. So we as a field, we as a society, we as humanity have to do better for the individuals that we always stand up and say that we're here to, help and serve. If you have an AFLS that's lit up like a Christmas tree, awesome. That's great. You've made a lot of progress. What does that mean? How does that translate to actual life? So I think quality of life measures and looking at what do these goals, quote unquote, have, like what impacts do they have on this person moving forward to actually enhance and grow their life. A recent study or survey done by the National Council on Disabilities showed that only 20% of dental providers in the United States are even willing to attempt to try and see somebody with an intellectual and developmental disability. And even out of that 20%, how many of them are successful? I don't know. I don't have those data. But what I can tell you is it's not going to be 100%.
Hey, it's the Cooperant Learning Podcast. I'm your host, Kyle Steury. With us, as always, is Dr. Steve Sparks. Steve, how are you doing?
Could use a nap, but otherwise we're doing all right.
We're here with our guest today. He's the Chief Behavior Analyst at Lee Specialty Clinic. He's currently pursuing a PhD at Cambridge College. Brandon Franklin, welcome.
Hey, how's it going?
It's going. We're happy to have you. Do you want to take a quick minute and introduce yourself to everybody?
Yeah, my name is Brandon Franklin. I'm a board-certified and licensed behavior analyst in Kentucky and Tennessee. Going on, 11, 12 years now. I've been certified. Time flies.
Aging yourself a little bit.
Yeah. I've worked in community settings. I've worked in institution settings. I've worked in school-based settings, homes, clinics. But more recently, over the last 4 years, I've been in the healthcare and medical setting, which I have found to be pretty rewarding, and decided that, I want to get my PhD and kind of, make this my life's work. So that's what I've been doing for a little bit now, and here I am with you.
Perfect. It's all led to this.
Yeah,
we were chatting
it's
before.
culminating to this.
We were chatting before. It's speaking of time flying, it's been 7 years since Hujraba when I first met you, and since then I see you on social media. Like, you're in Brazil, you're in Hawaii, you're all over the place. So don't sell yourself too short. I feel like you're living quite the adventurous life at the moment.
I'm not even sure I'm allowed in Indiana, so.
Yeah, fortunately, I've been lucky enough that people want to hear what I have to say, and they're inviting me to different places to do some work. I think healthcare is something that is extremely important, but is also kind of like an underrated aspect of programming that we do for individuals with IDD and autism and other disabilities that we work with. We want to focus on matching to red or walking across the street safely, but what I'm finding in my presentations and just traveling around and talking to people is, this hasn't really been something that they've thought about or wanted to address. But it's kind of hard to walk across the street if you're either dead or you have comorbidities that do not allow you to do that. So I think the healthcare aspect is a growing part of our field. People are starting to take notice. I'm very thankful and happy to help be somebody to disseminate and spread the good word. And hopefully it catches on and continues to grow because, we see great outcomes.
It's very cool. Do you want to tell everybody kind of like what you're working on as far as your dissertation goes in regards to dental procedures specifically, and kind of maybe elaborate on like why you chose that area or that specific focus?
Yeah, so my dissertation focuses around the idea that individuals who are going to the operating room under general anesthesia to have routine medical procedures completed, the idea is that those individuals can be desensitized. through an educational program in desensitization methods and shaping. Because it was like when I first got here to this clinic, I did an early data set on 60 patients that we had who came directly from the operating room to see us. Out of that 60, I was able to kind of whittle it down to 40 participants, and found that almost half of those individuals needed no restraint. They just need like a weighted blanket or hand redirection or just reminders. A third of those individuals needed no real intervention at all. They walked in, they sat down, opened their mouth, and cooperated, and then the other third needed some pretty heavy intervention. But if we're looking at 40% of people who really didn't need a ton of intervention, did they really need to be under general anesthesia in the operating room? Or is this something that if we start writing programming for, have assessments for, or have teaching protocols for, and we start implementing this early with our adolescent learners or even as kids with preventative practices, is this something that we would be able to avoid in the future? Because like I said, we had 40% of people, did they really need that? And on top of that, general anesthesia isn't all that great for your body. It's something that, 1 in 250,000 deaths occur per instance. As far as death is concerned, it's safe, it's a routine, but it's not great for your organs. It's not great for your body to be medically induced into a coma if it doesn't have to be. So when you think about preventative and routine medical care, that's something that we all go and we all do every 3 to 6 months, depending on your treatment plan. But it shouldn't be something you have to be put under general anesthesia and put your body through that sort of trauma for. So that's the idea, is that we can take adults who have been deemed too behaviorally challenged and too uncooperative and, quite frankly, dangerous, that they have to be seen under general anesthesia for their dental care. We can bring them to our clinic. We can run a baseline and show that we still don't have these skills. Then we go through a treatment program of education, modeling, and desensitization, showing what we're doing, working on that together, and then we go through the actual gradual and incremental exposure of these aversive stimuli to the individual, and then with their assent, of course, as it will be throughout the entire process. Is it okay if I go ahead and polish your teeth with a prophy motor? Is it okay if I go ahead and floss or apply fluoride? And through the intervention, you'll start to see that more steps are going to be completed, more steps, more steps, more steps. And then after we're confident that this individual is able to complete these steps, we are going to go to a community dentist provider or a community dental provider, and we are going to show that without intervention, without this dental provider necessarily being trained specifically in this sort of dentistry, that this individual can now sit in the chair and have their teeth cleaned without being restrained, without sedation, without coercion, without any real intervention. And the idea is that if you're having to go under general anesthesia in the operating room, the average wait time in the United States is something like 280 days. And the people who come to see us come from all over the state of Kentucky. How many dental providers do you pass on a 3-hour trip across the state? Probably thousands. So the idea is to take individuals who have fears and phobias, as far as dental procedures are concerned, desensitize them, and then generalize this to the point to where they can go and be seen in a community provider and they don't need any special interventions. Hopefully, the tools and resources and procedures that I use are going to be such that anybody and everybody out there, no matter what resources you have or where you are, you're able to pick up this protocol and use it and take your clients or your learners to any dentist around them after you implement this and have successful treatment.
I know in Michigan, a lot of the providers who have the services with the general anesthesia for individuals with some sort of delay or maybe traumatic history, it's many months, if not years, that they are booked out. And sometimes you can't even get on the list unless it's really bad. And so it seems that people are having to wait until it's gone way too far before they even get that treatment.
Yeah, so unfortunately, regardless of the ADA, which was the Americans with Disabilities Act passed in 1990, unfortunately, even though that's been passed and is supposed to guarantee rights and healthcare and access and all these different things, a recent study or survey done by the National Council on Disabilities showed that only 20% of dental providers in the United States are even willing to attempt to try and see somebody with an intellectual and developmental disability. And even out of that 20%, how many of them are successful? I don't know. I don't have those data. But what I can tell you is it's not going to be 100%. It's not going to be every single one of them. So, it depends on what that individual or what that individual provider, how far they want to go, how much resources and time they want to, contribute to this individual and their service, or do they just want to say, send them to the OR? That's all we can do. I'd also like to find out how much is the caregiver's decision and voice weighing in this. So are there providers who are saying, oh, we can try it, we'll do our best, we had one incident, it's okay, we'll reset and we'll come back? And how many of those caregivers or guardians are saying just send them under general anesthesia? Ultimately, where's the sell job? Is the sell job with the providers? Is the sell job with the caregivers and the guardians? Or is it a little bit of both? Because, social validity is huge in our field. You can write the greatest plan in the world. If it's not socially valid, nobody's going to use it. So part of, my exploration in my dissertation here is to figure out who needs to hear this, who needs to see this, and who should I target these interventions towards.
Yeah, in my experience, it's very much nobody knows where to turn or what's available. We're just calling everywhere we can to see who will even give us a chance.
Right.
And then, okay, here's these 3 places. I guess that's where we'll make an appointment, even though it's going to take us 6 months to a year or more to get in. And then, unfortunately, from our perspective, we're only able to be with a consumer once or twice a week for an hour or two at a time, working with the behavior plans. And so we're not even able to do a true desensitization program like you'd want to in the amount of time necessary to get them the care they
At least
need.
not with a lot of fidelity.
True. Yeah.
Yeah. And, kind of what you're describing is in 2014, Cron and Fox had an article in what they described as the cascade of disparities. And I believe this is going to be included in the show notes. I'm pretty sure that article is in the QR code that I sent you, Kyle.
If it's not,
Essentially,
I'll
it
find
shows it's like it's almost like an image that kind of shows how systemic failures and just things that aren't noticed and lack of resources, lack of education, kind of lead to individuals and their healthcare being neglected, not intentionally, but being neglected, and then these poor health outcomes taking place. So it all really starts with, people who have disabilities are born with higher rates of adverse health conditions, and we kind of already know that. Like, that's just the nature of the beast. That's how it is. That's what we're working with. So what are we trying to solve? This problem. But with that, you're looking at disparities in attention to care needs. So, and anybody listening out there, and you too, I'm sure when you walk into a home, I'm sure you've seen instances where you've noticed something's kind of off or something's wrong or there's needs that aren't being met, right? And sometimes that's just a lack of education or a lack of resources on the caregiver's part or guardian or whoever may be with that person. So that's where we need to advocate, like as behavior analysts and other service providers, is when you notice something, you need to advocate and help that family or that participant get the care that they need, right? Because if that doesn't happen, eventually we have disparities in preventive care and health promotion practices. And I'm talking about like healthy routine, like getting enough sleep, eating healthy, moving your body and getting exercise. Brushing your teeth is a huge one. We see that so many times in our clinic where we come in and we're like, who's brushing their teeth? Are they brushing their teeth or who's brushing their teeth? And Nobody's brushing their teeth. So the lack of programming and the lack of intervention and routine, like a healthy routine lifestyle, what that will do is that will lead to disparities in equitable access to healthcare. Because after you're not brushing your teeth, eventually you're going to have some sort of pain. You're going to have abscess. You're going to have dead roots. You're going to have cavities. You're going to have something go wrong in your mouth that's going to cause pain. And I would encourage all of the listeners and anybody else out there. Dr. Tim Vollmer's starting to do some research and has over the past couple of years on SIB and how that SIB is potentially related to healthcare issues. We have a lot of people who come in crisis through SIB, physical aggression, whatever they're struggling with. They'll come in, we'll look in their mouth, and it's a mess, and say, well, obviously, if you look right here, you see that huge white circle in their mouth the size of, a quarter. That's an abscess. That's why they're beating on their face every single day. You administer the local anesthesia, take care of it, and your patient just lets out this huge sigh of just, oh gosh, I feel so much better, so much relief. So if we don't have these preventative practices and we aren't able to get equitable access to healthcare like we just described for the last 5 to 10 minutes, eventually what you're going to have is you're going to have chronic illness, disease, and death. And essentially people with disabilities are dying 20 to 25 years earlier than the general population. Why is that? It's because everything I just described. Eventually, after years and years and years of sleep apnea, eventually after years and years and years of poor health practices, poor diet, if they're sitting on the couch watching TV and we aren't encouraging them to get up and move or do anything, but they're behaving themselves and I don't have to work any harder, I'm cool with that. That's why people are dying at the age of 50. So we as a field, we as a society, we as humanity have to do better for the individuals that we always stand up and say that we're here to, help and serve. So
Yeah, and I think it's important to remember too, whenever you are experiencing the self-injuries or any violent target behavior, like with Tim's research, we always talk about aversive conditions being motivating operations for aggression, but we tend to think about that towards other people. And in our work, we'll see it towards oneself just as much. It doesn't matter if that aggression is towards the person next to you, or if there's no one else available, then we see a lot of SIB. And so that's why that medical rule out is so important. And why whenever we're doing our assessments, we're like, all right, when was the last time they saw a dentist, and using that information hopefully to our benefit.
Yeah, I had that as you were describing that scenario with the abscess. I had literally that scenario probably a year ago where it was self-injurious behavior, and somebody just kind of in passing was like, oh, she can't eat, can't have syrup on her pancakes because of her tooth pain. Like, tooth pain? When were we going to talk about that? That was never brought up. So,
and the crazy thing about abscess is, if you have one, you come in, it gets bad enough that can get into your blood system, like your bloodstream, your blood system, your circulation. And if it causes an infection, you can die of sepsis. Like, you can die of a staph infection from having just an infection in your mouth that eventually gets into the rest of your body. So these are and we also sometimes we have them where we have to take care of, that instance immediately because they can swell up and close up the airways. So abscess, and there are a lot of dangerous conditions that individuals can have and suffer from that we're not even really addressing or looking for. So it's I know, it's just really sad.
So phobias are kind of the barrier here, some of the barrier. Staff and guardian education and caregiver action is also part of that barrier. But phobias would be kind of what we've identified as, this is why somebody might have an aversive reaction to being taken to an area like the dentist or something like that. Do you want to go through kind of phobias from like a behavior analytic standpoint and kind of like how you conceptualize that, and then take that into kind of systematic desensitization as an intervention for somebody who might not be familiar with it?
Yeah, so ultimately, before you can desensitize something, you have to have a phobia. There has to be some sort of fear there. And phobias are technically, for the most part, the accepted definition is something like an exaggerated or inexplicable logical fear of a particular object, class of objects, or a situation, something like that. So the problem I have with that is the word inexplicable, because we as behavior analysts know how behavior occurs, how it's conditioned, how things happen. So um, there's an article from 1977 by a guy named Rochman, and it's essentially the conditioning theory of fear acquisition. And he has 3 different ways that you can acquire fears and phobias. He says they're acquired through direct exposure, or fear information. So with direct exposure, let's just say like you have a fear of dogs, right? Direct exposure would be like an instance that you had, like you were bitten by a dog when you were a child. So therefore, for the rest of your life, you're going to be fearful of dogs because that happened to you when you were younger. There's an observation pathway to where you observe somebody else get bitten by a dog. And, oh my gosh, I'm scared of that. That's not going to happen to me. Then there's a last way, or a last pathway, and it's called fear information. It would be you heard about somebody who got bit by a dog, or somebody told you about getting bit by a dog, or you saw it on TV. And this, I don't know how young your audience is, but I think you guys are probably close to my age, judging by your weathered faces, by your lack of hair. Do you remember what was the show called? What was it? Unsolved Mysteries.
Of course.
Dude, that music comes on and you just get chills all over your body because you were like
Terrifying.
5 years old watching this crazy stuff on TV, right?
And they had the like extraterrestrial episodes too, where
Yeah, dude. Like I was so scared of aliens and Bigfoot when I was a kid.
Mm-hmm. Yep.
Because they would talk about that stuff, and you're like 5 years old watching this, and your little brain is trying to decipher what's actually real and what's not. Could this happen to me? And like that's fear information. I mean, eventually some of us probably grew out of it. Some of us didn't, maybe not. I'm not really sure.
I had
But
booby traps all over my parents' house growing up, just like trip wires and stuff like that. And you can ask my wife, I may still do that sometimes. You never know.
Yeah. But that's fear information.
I thought I grew out of it until you mentioned it again just now.
Right. Yeah. And then Robert Stack coming on with his creepy voice. It was just the whole vibe. But what I'm saying is that's fear information. You watch these things, you ingest these things, whatever the media or whatever somebody is telling you. If your mom tells you, don't cross your eyes because they'll stick that way. That's fear information. So those are the 3 different ways that you can acquire fear or phobia, right? So from then, it's really just reconditioning what you've been conditioned to. Because, really all it is just the tolerance of an aversive stimuli that has previously induced fear or anxiety responses. So in 1958, Joseph Volpe, he published a book called Psychotherapy by Reciprocal Inhibition. And essentially this whole book walks you through systematic desensitization, right? So the step 1 is to identify a hierarchy of anxiety. So when you do that, what you're going to do is you're going to take whatever your fear is, and let's just say it's like a spider or some sort of insect. That's a really simple example. So if that spider insect is your fear, the easiest, least intrusive thing that you could potentially do is think about a spider, right? Because you can turn that off real quick in your head. There's not an actual spider. You're not actively doing it. You're just thinking about a spider, right? Then you can move up to like looking at a photo of a spider. Look at a real spider in a closed box. Hold the box with the spider in it. Let a spider crawl on the table in front of you. Let a spider crawl on your shoe. Let a spider crawl on your pants leg. Let a spider crawl on your sleeve. Let a spider crawl on your bare arm. Do you see how that gets more intense and intrusive as you continue to move up that hierarchy, right? Yeah, so your fear response is going to be stronger. It's real. It's something that's actually happening when you get to the point of that spider crawling on your arm. Whereas thinking about a spider is something easy to start out with, right? So it's kind of taking this huge goal of like let a spider crawl on your arm, and you're breaking it down, not to necessarily a task analysis, because a task analysis is going to be, pick up the spider, put it on your arm, tolerate that. But it almost is kind of like a task analysis pseudo type treatment plan to where here are the steps that we're going to do to break this one huge step down into a bunch of little steps to eventually get you there, right?
Yeah.
So then after you've identified that hierarchy of anxiety or fear, what you're going to do is you're going to teach relaxation techniques, okay? Because the idea is counter conditioning. The theory behind all of these desensitization models, especially systematic desensitization, is you cannot be anxious or fearful if you are relaxed. If you are emitting a relaxed, composed response when presented with these aversive stimuli, you can't be fearful. You can't be both. It's not something that you can do at the same time. So you can work on something called progressive muscle relaxation. That's, tensing up your muscles as tight as you possibly can. And there's like 19 different groups of muscles throughout your body that you can target. And then what you do is through that 15 seconds, you just let it go slowly and easily all the way to a relaxed state. And what you're doing is you're teaching and you're training your body and your mind to understand what a relaxed muscle feels like. I used to be terrified to fly. I'm not terrified to fly anymore, but I used to be terrified to fly. And part of what would happen is I would get on these planes, and the whole time I would tense up as much as I could. And I would wonder, why am I so tired? Why am I so sore after that flight? I don't get it. It's because I spent the last 3 hours with every single muscle in my body tensed up, like I was in a pose down in the Mr. Olympus competition. You know what I mean? Like, it's you don't realize your responses until you actually practice them. So progressive muscle relaxation will help with that. Breathing techniques, 4 seconds in, hold for 4 seconds, 4 seconds out. This is shown to drop your heart rate, calm your body. And then positive imagery and visualizations. I always like to use kind of like an if-then in this when I work with my patients. So what are you doing after this? How are you rewarding yourself? What do you have to look forward to after this? I know this isn't the most ideal situation that you want to put yourself in, but it's necessary. It's a necessary medical task. What are you doing after this to celebrate? Let's think about that. Let's talk about that because that's going to be fun. You can also put yourself, the old Happy Gilmore, go to your happy place. That kind of follows along the same line. So positive imagery and visualizations and understanding what you're working towards or taking yourself out of that present situation and just relaxing and finding something that, is positive.
It
So then the
seems
last,
kind of like this is
yeah,
what we're all doing naturally, because getting your teeth cleaned or drilled or what have you is aversive to everybody. It's not a pleasant experience necessarily. I mean, maybe there's some people that enjoy it, but metal instrument scraping on my teeth is not my idea of a fun time. But we're all kind of doing this naturally, and it's when it has that really intense fear response that what we naturally do may not be enough. And so it's kind of like a progression of the same process that most of us would do naturally anyways, I would think.
yeah. And that's why they have TVs. You go in and they're playing like HGTV, like Property Brothers on loop. You know what I mean? To try to get, your mind somewhere else. You thinking about something other than the scraping of your teeth because, one more stat to throw at you, the general public has dental phobia at about 12% is about, and that's just the avoidance of actual dental care for most of them. The IDD population, I believe it's 21%. And that shows itself in a vastly different way because most of us, we don't want to go to the dentist. We just don't go. We just don't make appointments. We just don't go. For individuals with disabilities, sometimes they're made to go and you force them to go. And then they get there and behaviors communication. I don't want to be here. I'm scared. How do I get out of the situation? Flip a table, flip a chair, scream, smack somebody, run out of the building, whatever it may be. So that's why they kind of show themselves in vastly different ways. So yeah, it's very real and it's there. So the last step of this systematic desensitization is incremental exposure. So what you're going to do is you're going to take that first step of the hierarchy of anxiety and fear. And what you're going to do is you're going to pair that with the counter conditioning measures of the progressive muscle relaxation, the deep breathing, the positive imagery and visualizations, the distraction of other, like watching TV or listening to music, or whatever other interventions you may put in place. You're going to take each of those steps and you're going to incrementally expose this person to that aversive stimuli, and then it's going to get more intense and more intense and more intense and more intense and more intense. And the idea is once you tackle that first step of thinking about a spider without having your heart race, without getting sweaty palms, without really having that fear or anxiety response, then you're going to move to the next step. And what you're going to do is you're going to get used to, looking at a photo of a spider. You're going to get more used to looking at a photo of a spider. The more somebody is exposed to something, the more acceptable it becomes to that individual. That's way, 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 way back in my bachelor's of criminology. I can't remember exactly who that was. But there was a theory I did a report on, and it basically said that the more somebody is exposed to something, an environment, an idea, like anything, the more somebody's exposed to something, the more acceptable it becomes to them. And the same thing goes for desensitization. So once you do that and you get to the last step and you're able to let a spider crawl on your bare arm without an anxiety or fear response because you're using those counter conditioning measures, and spider's really not that big a deal anymore because I've been looking at a picture, I've been thinking about it, it's been in a box, it's crawled on my shoe, it's crawled on my leg. At this point, letting it crawl on my arm really isn't that big of a deal because I've seen spiders now. I've been around spiders. They don't hurt me. They haven't done any. They're very predictable to me now. Okay, I'm gonna let it crawl on my arm, and bing, bang, boom, you've desensitized yourself to spiders. I think the biggest component of desensitization that people fail to realize or don't implement is that it needs to be implemented in your programming at home with parents, with caregivers, day programs across the board. Because you can't bring somebody into a health clinic once every 6 months, once every 3 months, and then try to desensitize them real quick for 5 to 10 minutes before an appointment. It's just not going to work. It doesn't work like that. So there are kits and there are things online that you can go out and you can buy. So anybody listen to this, go out, look for those things. I think there may be a link in that QR code to where you can go look for like a dental desensitization kit. And that just shows all the tools and all the things they use in a dental procedure that you can take home and you can start to get used to those things before you generalize them to another setting.
So this sounds like I'm changing the subject, and I'm not. How does VR play into all this virtual reality? Because this is big in your presentation that I looked at. How have you leveraged VR to help with this desensitization?
Yeah, so VR is pretty cool. It's not necessarily for everyone because there's a certain threshold of learning that some people have and some people don't, where they're able to understand from, instruction and video modeling and all that. You also have to be able to wear a headset and be able to, kind of tolerate having something over your face for about 10 minutes. So I just want to preface with saying you need to have a very specific type of learner who can do these things, tolerate these things. But other than that, virtual reality is great because it combats barriers to treatment. That's number one. These headsets are mobile. You can take them anywhere. You can do anything with them. And this actually started out of an individual we were treating here in the clinic who has agoraphobia. And he didn't want to come out, didn't want to come for desensitization sessions, didn't want to come to work on anything because he just was afraid to leave his house. But his mom would make him come for appointments. And when he would get here, he'd be super anxious. He'd be very nervous. He'd be very fearful because he didn't know what to expect. So the idea was, we have this headset. I'm going to take it to him and I'm going to put it on him and train him and get him desensitized through that set. But other than that, it combats barriers to treatment. It provides realistic experiences safely. You can stop it at any time. There are no tools involved. It's just the headset. It's easily accessible and readily available. I think with all of our equipment, cameras, everything included, 2 headsets, it was maybe $1,500 at max. And then there's tons and tons and tons of literature out there right now that shows that virtual reality is effective. It's something that you can do. You see results from it, and it's just a great tool to use. It's the newest, latest, and greatest, most technological advancement that we have currently. I feel there's a lot of people kind of rushing to provide services and research with this, and that's great because it provides a very realistic training environment in a very safe manner, and it erases a lot of those barriers that our participants may face. So what we did was we wanted to look at, can we play a 5 to 10 minute video in a VR headset for somebody before an appointment and see like what effects that would have. Would it make them feel more comfortable with the appointment they have after the VR session? Would it not help at all? Would it help with their physiological biomarkers? Like, would it affect their vitals? Would their blood pressure drop? Would their heart rate drop? Anything like that? What we did was, and we're still kind of in the process of it, it's kind of slowed down. I wanted an N of 20, and right now I think we're like 17 people. It's kind of trickling in. I think we have another one coming in, so we should be done with it pretty soon. But we would bring individuals in, and the inclusion criteria would be that you were over the age of 18, you had to have a diagnosis of IDD, you were a current dental patient of the Lee Specialty Clinic, you're able to understand and answer questions about dental anxiety, you have to have some level of dental anxiety. You have to attend an appointment for restorative or hygiene services. And this is very important because a lot of the studies that you're going to read about this type of stuff deal with hypotheticals. How would you feel if you had an appointment today? How would you feel if you had to come in for dental treatment? This study was you have an appointment in like 30 minutes. You're going to do that. Like, you have this. How are you feeling about it? This isn't a hypothetical. This is real. This is like actually going to happen. So you also needed consent from the participants themselves or the guardian. And if that happened, we also got assent from the participants. And then they also had to tolerate wearing a VR headset. Those were kind of our inclusion criteria. The setting was a special needs outpatient clinic where I work here at the Lee Specialty Clinic. We did everything in the dental operatory. So we had dental chairs, we had all that type of stuff. Like I said, we used like a MetaQuest 2 headset, GoPro Max 360 camera. We need memory cards for the storage, tripods. I used one of those flexible tripods, like the ones you can like wrap around a pole or something. Because what we did was we took that camera and we put it on the headrest of the dental chair, and we wrapped it around there. And then what we did was we had the dentist actually work on the camera like it was the individual's mouth. And the idea behind that is when you put on the headset and you sit back in the chair, it looks like they're working right there in your mouth with all the tools and the sounds. The only thing missing out of that were the sensations, and it's really hard to duplicate that until you're actually, doing the procedure. But as far as sights, sounds, all that type of stuff, almost every sensory issue was covered. And then what we would do is we would bring individuals back. We had two different groups. We had a group where we took their vitals immediately as soon as they came back, and I saw that we were dropping heart rate quite a bit after the VR session. So then I switched to also having people come back and sit for about 10 minutes because I wanted to see, was it just the walking back and being unsure and then letting your heart rate drop? And what we found was there was no change in physiological biomarkers after you sat for 10 minutes. But we saw that there was a drop when we brought people back and immediately took physiological biomarkers and vitals, which led me to believe that it was just the walk back and the unsureness of whatever was happening. So I didn't see any changes in physiological biomarkers or vitals. However, we used a modified dental anxiety scale to test self-reported anxiety in individuals before we played the VR session for them. Then we took the modified dental anxiety scale afterwards to see if their answers changed on their self-reported anxiety. Am I more prepared for this? Do I feel better going into? Am I still as anxious or fearful going into this appointment as it was when I first got here? So it asked you 5 different questions. And the 5 questions are, does waiting in the waiting room for dental treatment make you anxious? Does having your teeth cleaned make you anxious? Does dental treatment make you anxious? Does having a tooth filled using a drill make you anxious? And does getting a shot in your mouth make you anxious? Now, I modified the actual modified, so it's almost like a modified. But I did that because I decreased the amount of answers. Because there's like 5 different options, and it was like slightly, kind of slightly. Mostly, there were so many that our 2 pilot participants got really confused and really couldn't answer the questions for us. So I dropped it down to 3, no, slightly, and yes. So you're either anxious, you're kind of anxious, or you're not anxious at all. And what we found that our individuals had an average score of 11.3 on the modified Dillon anxiety scale. And just to give you some reference, the highest you can score is 15. And then the threshold for phobia, for dental phobia, would be 11.4. So we were a tenth of a point away from our average participant qualifying as dental phobic, right? So we played these videos for them, and the post-condition average was 8.46. So that is a drop in 28.74% in self-reported anxiety. And all of these individuals were able to leave the session, walk right into the dental operatory, and have their dental procedures completed without issue. Most of the feedback I got from them was, once I was able to understand what was going to happen, in what order, and what to expect, I felt better. So,
Nice.
yeah, and kind of the whole thing with desensitization and phobias is the unknown. If you have a phobia of something, you're going to avoid it. You're not going to put yourself in that situation. You're not going to try to confront that environment or that stimulus. So when you do, you realize it's really not that bad. I don't understand what I was afraid of. It may not be the most pleasant thing in the world, but it wasn't what I had built it up in my mind to be. So once individuals, encountered these VR sessions, they felt more confident that I knew what to expect, when to expect, what it would look like, what it would sound like, the setting I would be in, all these different variables in their minds that kept them from seeking out services or from being anxious when they came to get services. So the big thing with this was, with the conclusions, was that patients reported higher anxiety for restorative appointments, which is normal. It's where you got all the sharp tools, the needles.
Mm-hmm.
Like I said before, participants reported knowing order of events helped in the appointment. One super unexpected and very, almost like, I want to explore that a little bit more, was there was an improved score across all procedures for needle anxiety. And when I say that, some of our participants weren't shown a needle. They came in for a cleaning and there was no needle involved. What I'm saying is, even those participants on average said or scored lower for needle anxiety, even though they weren't prepared for that, they weren't going to have it. So I don't know if that's just, well, I'm not going to have it today, but I do feel better, or if because they were prepped for this dental appointment, that it didn't matter what that dental appointment involved, they felt better and more prepared and more confident because they were empowered over, with autonomy over what they were doing. So that was something
Nice.
that I was super, super, super interested in and may even look at further. But
Because needle phobia could go a lot of directions too. I mean, not just specific to dentistry.
yeah, and the thing is, I think in the general public, needle phobia is at 5%, but in the IDD population, needle phobia is at about 15%. And the thing that's really important about needles is, think about a lot of the preventative healthcare that you have, the immunizations and the blood draws. There could be something wrong within me, and we don't know until we draw my blood. Or I may be really tired, or I can explain what I feel, but I don't know why. I think it's even more important with the population that we work with, because they struggle with communication in general.
Yeah.
So it's going to be hard for those individuals to tell you specifically what hurts or what's wrong. So blood draws are extremely important, because they're kind of almost pulling back the curtain inside the body to understand what could potentially be wrong and lead to a pathway to treatment for individuals. But if we have a needle phobia and we aren't receiving those blood draws, and we aren't, accessing that information, we don't know which direction to go in and what to do. Same for immunizations. If you're not getting immunized, you're going to get sick. You're going to have poorer health outcomes over time. And I think we're starting to see that within our general population as well. If you're not being immunized, you're going to get sick. That's all there is to it.
I find the needles interesting from a conceptual standpoint as well, even though I know you're more worried about helping people in the here and now. But the pairing between the needle and the stimuli in that environment, and basically what you're doing here is slowly and systematically breaking down, that pairing between, or now the aversive stimuli and getting something done, or that assumed perceived aversive stimuli and the actual experience. You're going through it, nothing bad's happening, systematically working your way up that hierarchy. I wonder if it's just because needles are paired with that, at least through our verbal behavior, that now you're breaking that pairing without even that being the intention at the time.
Yeah, I think ultimately it's the prick. I think it's the stick. I think that it's paired with something unpleasant. Um, it's going into your body, and when I was younger, I was afraid of needles too. And, it's something that we learn to tolerate as we grow because of the implications that you might, encounter if you don't. When you're a kid, or if you do have a disability and you don't have decisional capacity to understand, like, what's going to happen to me if I avoid these things or I don't do them. Like, somebody else needs to make that decision for you, and they do. But that's a whole nother can of worms to get into. I think the main, and it kind of going back to what you were talking about, like helping the here and the now, kind of something that I'm really getting into lately is, and I think this is going to be a big message moving forward when I speak about these types of things and some of the materials and studies that I may be hopefully putting out at some point in the near future, is that the goal, let's just take blood pressure for example. Blood pressure could be a goal. We take blood pressure, we get somebody to sit down, they hold their arm out, we squeeze the arm, they tolerate that, we get a reading, right? Goal, check. We checked it off. We checked off that goal. But what happens after that? You just got numbers. So until you actually take those data, those raw data of blood pressure and what that person's experiencing inside their body, until you take those data and you put a treatment plan in place to maybe make lifestyle changes, diet changes, medication changes, maybe lead to a blood draw and try to see what, if we have hypertension, what's the cause of that? What's the source? Or if we have low blood pressure, what's happening inside this person's body? So until we take those data, implement changes in a treatment program, and affect long-term outcomes, the goal, this is what I'm getting at, the goal shouldn't be a blood pressure. That shouldn't be the goal. But so many times in our assessments or treatment plans or behavior plans, or even at the doctor's office, let's get that blood pressure read. Okay, cool. But what after that? The goal should be the outcome. The goal should be that this individual lives to 75 years old and dies peacefully in their sleep, like I hope that we all do. At some point, we live a long, healthy life with better health outcomes. Taking someone's blood pressure is not the goal. The goal is a longer and healthier, more productive life. That should be our goal. The outcome should be the goal. So what I want to try to do is, especially through my work and what I'm doing, is transition that thought of, oh God, we took their blood pressure. Thank God. Okay, we can mark that off and move to something else. No, that's not the goal. And us as behavior analysts, we're probably not going to see that outcome. And I'm not saying because it's not going to happen, but how many of you out there have worked with somebody from the age of 18 to 75? It doesn't happen. So you're probably never going to see that. But that doesn't mean that you shouldn't be working towards that goal. That should be your goal. The fact that this person you're working with lives a longer, healthier life than they would have before, getting blood draws, blood pressure, all these other quote unquote mini goals that we have, they're just a vehicle to that goal. So I kind of want people to start thinking in those terms of, great, you got the blood pressure. That's not where this stops. That's where it begins. So it's not necessarily a goal, because a goal to me signals the end of something. I've reached my goal. Check it off. I'm done. No, this is just the beginning. This is the starting line to helping somebody change their lifestyle and the way they live so that they can have a happier, healthier, better life. And that's what I hope to do.
Yeah. To that point, I mean, it speaks to so much to kind of like our, yeah, I just think of, so many times, especially early on when I was just like, oh, this goal's mastered, look how many goals I mastered, and not really
Right.
thinking about what that means for later on, be it a health related outcome, be it, just picking, matching red to red, like whatever. I did it, but what does that actually mean? So I like that kind of call to action.
It's really
Like, what
about
does this
quality of
m-
life.
Yeah,
Quality of life
yeah.
measures are
What does
very
this do
important.
for this person?
Yeah.
Yep.
Yeah, because if you have an AFLS that's lit up like a Christmas tree, awesome. That's great. You've made a lot of progress. What does that mean? How does that translate to actual life? So I
Yeah,
think quality of life measures and looking at what do these goals, quote unquote, have? Like what impacts do they have on this person moving forward to actually enhance and grow their life?
I will say it is that's definitely a disconnect on our side too, because we're hired to come in and help with severe aberrant behavior. And then once we're like, all right, now they're no longer attacking people. Let's work on these pro-social skills. Let's work on these health goals. They're like, no, you've done what we're paying you for, and
Yeah.
move on out.
Get
And
out.
so
They're sitting in
that
the corner watching TV. We're happy. Yeah.
yeah, yeah, and so
That's
yeah, it
awful.
is a disconnect that I think we need to work with society as a whole on. Like, let's work on this person's total life, not just the one thing that was bothering you.
Agreed. Agreed.
Nearing the end of time, if there are any audience questions, this is your moment. Brandon, I think we covered everything that we had touched on. Anything else to kind of wrap us up or bring us home? I feel like you kind of already did.
Yeah, I mean, ultimately, make sure that you're looking into the healthcare of your participants, your learners, and the clients that you're serving. And I think, like I said, I think it's an overlooked aspect of our programming. It's starting to catch on, but really, your healthcare affects every reach of your life. And if you do have health issues, it could potentially lead to other problem behaviors. Um, I think we owe more to the individuals that we serve, and making sure that they are happy and healthy and living long, meaningful lives as they see fit, not necessarily what we see fit. So just start to look into healthcare, start to look into how you can help increase tolerance and increase access and advocacy and education for the individuals that you're providing supports to. And if anybody has any questions or needs anything, there's a QR code that I'm sharing with Kyle. That's all my contact information. Feel free to reach out at any time. I want to be a support. I want to be a resource for people who are trying to do this. Contact me anytime in any way, and I'll be happy to help out.
Very cool. It's awesome work. It's socially valid work. It's really cool stuff. So keep it up, man. It's good talking to you.
Yeah, you too. I appreciate you guys having me.
Brandon's the Chief Behavior Analyst at Lee Specialty Clinic. Thanks again.